to the
demo.
This was really good. Hello and welcome back. This is the third and last part of our Echo Starter Kit. In part 1, we showed you how to quantify left ventricular function. In part 2, we talked about aortic stenosis, and now we'll talk about another topic. But before we do so, first of all, you can always go back to the old lectures. You have them in your inbox, and you have them on our webpage. So if you want to look at them again, just go to them. And now, I will just hand it over to Anna and let her review some of the things we saw in the last chapter.
Yes, when we were talking about aortic valve stenosis, we were imaging the heart from a parasternal long axis view, which cuts the heart, now you know very well, somewhere here through the aortic valve. And we used also the parasternal short axis view at the base, where the aortic valve is always in the middle of our view. But now we want to see if you are ready to make your own diagnosis. So I propose we go through a test. Can you say which one of these aortic valve is a good one and which one is a bad one? This time we won't give you so much time, we want you to be quick. So just have a quick look. You can do it, it's really easy. You already trained your eyes. So quickly, the first aortic valve is good. The second aortic valve is really calcified. This cannot be anything apart from bad. Third is good. Fourth is bad. And still some other examples for you. Again, we have aortic valves, long and short axis. The first one, we see a lot of calcification. We cannot even distinguish the opening. This is a bad valve. Next to it, good valve. The third one, well, actually, I would say this is half bad because it's calcified, it's a rigid valve, but still opens. And the last one is a normal valve. We can say it's good. We also consider the aortic, the ascending aortic together with the aortic valve. Please do always consider them as a unique structure. This will help you making the diagnosis in complex cases.
But now it's time that we jump right into the third and last topic of the starter kit, the mitral valve, specifically mitral regurgitation.
The mitral valve, as a matter of fact, is an apparatus, and it consists of two leaflets, the anterior and posterior one, which are attached to the papillary muscles thanks to what we called the tendinous cord. And it's an extremely tender and complex apparatus, and different pathologies and diseases actually can affect it, causing mitral regurgitation.
Yes, and you can appreciate how tender the mitral valve is again from these beautiful images here. You see that the anterior and the posterior leaflet coapt actually along a certain surface here. And you can imagine that if you have just a little bit of leaflet retraction or tension on the leaflets or a part of the leaflet which is ruptured, you can easily get significant mitral regurgitation. You can appreciate how delicate these chordae are when you look at the mitral valve now from the ventricular side. Here, this is the papillary muscle, and right here you would see the chordal structures, which are actually relatively resistant, very strong, but still under certain conditions they can rupture, as you will see in a few examples that we're going to present to you during this lecture. From video images of the mitral valve to the mitral valve we see with echocardiography.
Exactly, Thomas, here is the mitral valve. I guess our colleagues are already able to recognize this view. We are using a parasternal long axis view, but now our focus is on the mitral valve. So we can see actually the mitral valve is really opening during diastole and closing during systole. I think it's a normal valve. What do you say, Thomas?
Yes, it's an absolutely normal valve. After all, this is my son here, and I hope he is normal. But you can see that the leaflets are not thickened. You can see that the opening and closing motion is completely normal. And
I'll tell
Anna,
you,
what is this here, though? Do you see these cordon
Yes.
structures there?
Yes, Thomas, don't get scared. This is nothing but normal. Actually, we can really appreciate the total apparatus of the mitral valve when we do image the heart, and these structures you are looking at are only chordae and papillary muscles. The only thing we need to do is scanning the aorta. The mitral valve, we do just tilt the probe anterior and posterior, and we get a full view of the mitral valve and its apparatus.
I think this is so important to understand because it's a cut plane technique, and to understand we have to get a spatial representation in our head, and to do that we have to scan through the entire valve, and sometimes you will see pathologies only in one cut plane or very at the edge of, let's say, the mitral valve. So to do that you have to image the valve like Anna is doing it by scanning back and forth. And to give you a better understanding of how the anatomy corresponds to the cut planes, we're going to show you some images now.
So we were cutting the heart in a parasternal long axis view, so right following this line, and the mitral valve would be actually this level. So you were looking at a normal mitral valve. Here's again another example. You can see really nicely the anterior leaflet next to the aorta, the posterior leaflet on the other side, and compare the length. The anterior leaflet is longer than the posterior leaflet. So this is a completely normal valve, opens really good. The leaflets are not thickened, but here I think we are ready for some pathologies.
Yes, Anna, this is definitely not a normal valve. It's a little bit thickened, and to pick up the pathology, it's not so really easy. You have to look very closely. Right here at this region, you can see that there's a little part of the mitral valve which is actually prolapsing into the left atrium. This is a flail or a partial flail leaflet, a pathology which can really cause severe mitral regurgitation. Now, to the next pathology here, don't get confused. This patient also has an aortic valve prosthesis. You see all these echoes here. And he also has a mitral annuloplasty ring. You can see this is a ring that was implanted during surgery. But the main problem is that the valve is thickened, and the patient has severe mitral regurgitation. It's a patient of mine, actually, who was operated and everything went fine, but a number of weeks after the operation, somehow a suture must have opened and he developed very severe mitral regurgitation. You can see part of the leaflet, again, prolapsing into the left atrium. A very difficult pathology indeed, but some pathologies are very easy to detect.
Yeah, for instance, in this case where we can really see in a zoom mode the mitral valve on the right part of the screen, and you can detect the missing coaptation of the leaflets, so the anterior and posterior are not even touching these. Without even putting color Doppler, you can understand a big, huge mitral regurgitation is behind this.
This is absolutely true. In many patients, you don't even need color Doppler. We'll talk about color Doppler later, but you don't need color Doppler to determine that there is regurgitation. The interesting factor here is that this is a valve that does not have a structural defect. Still, it's very incompetent. You'll learn later that we call this form of mitral regurgitation functional mitral regurgitation. But at this point, I think we'll just move on to another pathology, which is very frequently seen not in our part of the world, but in parts of the world where rheumatic heart disease is very frequent.
Exactly, and here we have a really nice example of mitral stenosis, where with this awkward motion of the anterior leaflet, we will call it later on in the chapter on mitral stenosis, doming of the leaflet, and it's, as soon as we see it, we can really understand mitral stenosis is there.
But again, don't worry about that now. Just keep in mind that if you have a valve which has a pathology such as this, it can also be incompetent. And finally, one other example, an example that you will frequently encounter in your echo career. It's just an example of a patient who is elderly. And in these patients, you will often find some form of papillary muscle fibrosis. You see this is relatively echogenic here. And mitral annular calcification, you have calcification of the ring. This is aging of the mitral valve, and these valves frequently leak a little bit. So don't be surprised to see this pathology. It does not necessarily mean that the patient has severe mitral regurgitation. Are you ready to see how these cut planes correlate with anatomy? Well, then we need to go to the simulator again. An atomic echocorrelation of the mitral valve. We have the anterior leaflet right here, which is closer to the transducer and closer to the aortic valve. Then we have the posterior leaflet, which coapts with the anterior leaflet right here. If you want to see the entire mitral valve, you have to just slightly tilt the transducer to scan through the entire mitral valve.
All these views were parasternal long axis views, but there's another view which shows you the mitral valve in details, and this is the apical four-chamber view. You're really familiar with it, but let's go anyway to the machine and see.
When you've seen this view before, we image from an apical window. Remember, it's the fourth, fifth intercostal space. It's where you would feel the palpitation of the heart. And then we image with the marker of the transducer, remember, on the lateral position of the body. So we image upwards and immediately you will see the four-chamber view.
This is really nice to see again, the mitral valve on the left.
Yes, you see the anterior leaflet, which is a bit longer, and the posterior, which is a little bit shorter. Let me show you this. Here, this is the anterior leaflet. This is the posterior leaflet.
Yes, actually, what I really like to do in my patient when I analyze the mitral valve is, again, after performing the parasternal long axis view with the tilting, I do it again here. So I focus on the anterior part.
Yeah, I'll show you this. I think this is a very important point that Anna is bringing up, because otherwise we don't understand the full morphology of the mitral valve, the full anatomy. So we have to scan the entire mitral valve. And we do that by tilting the transducer first ventral until we lose the mitral valve, and then back dorsal to the base or to the bottom of the heart actually. And then we see the entire mitral valve until we lose it right here. And then back to the standard four-chamber view. So this gives me an understanding of the entire mitral valve, and some pathologies, as you will see, can be located in very small regions of the mitral valve, and you'll simply miss them if you perform just one four-chamber view. We would perform a four-chamber view. Start with a view that cuts right to the middle of the mitral valve, right here. Look for regurgitation, and then again scan, tilting that transducer more caudally, and then back up until you see the aortic valve also in your field of view, and that would give you the more caudal portions, or the actual more cranial portions of the mitral valve.
So this view actually cuts the heart through the chambers as well as cutting through the mitral valve, as you can see, and we will give you another example of a completely normal valve. Focus on this, it will help you to recognize pathologies onwards. And we will start with the first example of pathology. This is a really nice example of flail leaflet. As you can see, the mitral valve is really thickened, both anterior and posterior leaflet. But a part of the posterior leaflet is going beyond the mitral annular plane into the left atrium, and it brings with it a part of the tendinous chordae. So this is a classic example of flail leaflet causing, you will see with practice, really massive mitral regurgitation. And here is a really nice example again of a functional mitral valve regurgitation. We don't have the color Doppler, but we can easily assume that the jet would be really huge because the mitral leaflets are not coapting, and this is extremely related to the left ventricle remodeling.
So this would be a wonderful example of functional MR. You can really see the hole here, and if you can see the hole, you don't need color Doppler. Regurgitation for sure is going to be massive. And finally, this would be an example where you have a thickened mitral valve here, and you have something actually which moves on the mitral valve, attached to the mitral valve. This is a patient who had endocarditis, an infection of the mitral valve, which can also cause very severe mitral regurgitation. And finally, this is an example of a mitral valve prolapse, a very common disease. The typical features here are that of a very thickened valve, which prolapses. If you look exactly, you see that a large part of the mitral valve actually extends below the annulus into the left atrium. A number of examples which I think show you the large variety of mitral valve pathologies. And many different diseases can lead to regurgitation. But before we really detect mitral regurgitation, we have to understand how color Doppler works. And this is going to be the next part that we're going to look at in our patient demo. First, we turn the color Doppler on. And then we get the color Doppler information in the region of interest, the color box. How do we interpret the different colors we have? Well, let's freeze the image. And let's look at the bar here on the right upper hand, where you see how the color is actually displayed. Red would mean flow towards the transducer, and blue away from the transducer. The lighter the colors, the higher the velocity. And if the velocity exceeds a certain limit, then we get a mosaic or a mixture of different colors. In this case, in this map, you will also see green if you have a high variability of flow within a certain region. Now, how do we interpret this? Here is a frame during the filling phase during diastole. We see red, in other words, flow from the left atrium into the left ventricle. This is normal flow. If we just go back a bit, we see that there's even a frame where the velocity is so high that you have this mosaic color. The reason is simple. He's a young individual and he has a very high cardiac output. If we go to a systolic frame, we see that there is no backflow. Let me find one here. Here, there is no backflow of blood from the left ventricle into the left atrium during systole. In other words, there is no mitral regurgitation. In the cases we'll show you now, indeed, there will be mitral regurgitation of various degrees. So remember, there is structural MR and there's functional MR. The difference between the two is that in structural MR, you have some morphologic abnormality of the valve, while in functional MR, the valve is structurally normal, but something has happened, let's say a dilated ventricle or some other problem that causes leaking of the valve. Now that you understand why we can have mitral regurgitation, we need to figure out how severe mitral regurgitation is. Here is an example of the two cases I showed you previously. Now, Anna, there's a difference between the two, right?
Yes, we had a flay leaflet of the posterior on the left, and we had tethering of both leaflets on the right, but actually mitral regurgitation is massive in both cases.
Yes, I agree. I mean, why do we know it's massive? Well, the first thing we see is we see a lot of color entering the left atrium. So almost half of the atrium is kind of full of color here, and this is true for both cases. The other reason is that we have a lot of flow that comes here already before the valve. You see right here, there's what we call flow convergence. We'll talk about that in the main course, but here, just for you to understand, this is a marker of severe MR.
And then we have the different orientation of the jet, which actually helps making the diagnosis, understanding the morphology of the valve, but will come also later on.
We'll come to that, but it's a very good point because the direction of the jet will be very important later on. But we have other forms of mitral regurgitation as well. What do you think about this mitral regurgitation?
Yeah, here we have actually a really nice and crystal clear prolapse of both leaflets. But actually, when we look at color Doppler, we get a little bit disappointed somehow because I would expect it more mitral regurgitation here is only mild, I would say.
Which only shows to prove that the degree of morphologic abnormalities does not always relate to the severity of MR. This is a beautiful example where MR is relatively little, even though we have massive thickening of the mitral valve. So again, a teaching point. To make it easier for you to grade mitral regurgitation, we put together 4 loops, and we'll go through these 4 loops and explain how we would quantify them.
Yes, just by using our eyes, when we start with the first loop on top, we can see actually that we do not have such a big regurgitant jet. We only have a small jet, only
barely
in
visible,
blue.
actually.
Exactly. No mixing colors, no turbulent flow.
Yeah. So this is almost very difficult to pick up. You'll see this in normals as well. It's a very common finding to have a little bit of mitral regurgitation.
And this, in the second example, actually, we have more MR. You have to concentrate, remember, on the blue part of color, which goes into the left atrium, so away from the transducer. And here we actually can really talk about more serious degree of MR.
But still nothing to be concerned about. It's probably only maybe mild to moderate, but more towards mild, I would say. And here on the right, you see that there is a larger jet. We have more of this flow convergence zone that I talked about. Now it's actually visible, while in this example, we could not see flow convergence. Now we do see it. And we have a jet that goes right here into the left atrium, into the middle. Why do you think this patient has mitral regurgitation?
Well, actually, this mitral regurgitation is functional and is related to this clearly compromised left ventricle. And this is the reason why also the jet is really central.
Yeah, very severely dilated left ventricle, poor left ventricular function. So I certainly wouldn't want to have this ventricle. And finally here on the lower right, this is the extreme. Here we have a jet which actually almost completely fills the left atrium with a lot of flow convergence zone, a lot of color. Again, mainly blue, meaning that it's going away from the transducer. And if you time that with the ECG, you would also see that it occurs during systole. That's exactly when mitral regurgitation occurs. So putting all this together, what do we have? Well, we have trace MR here. We have probably mild MR here, moderate, and finally severe MR. So I would say just by these 4 examples, which you can use as a reference, you can eyeball MR. Now there will be situations where it will be more difficult, and of course you have to produce good images to see MR. But this is something that we really want to stress in the main part of our course, where we'll have a chapter which is dedicated solely to mitral regurgitation and to all the little tips and tricks that we will teach you.
And here are 4 examples. So can you tell us which MR is severe? I will walk you through, take your time, and let's make the diagnosis together. For sure, in the first loop, we can say this MR is not severe, maybe it's mild to moderate. And here, the third and the fourth are only, I think, traces or mild MR. As you can see, it really is crystal clear. This is the case with severe MR, with this really broad jet. See, it was easy. You make the diagnosis, I'm sure of it.
Exactly, Anna. This is the teaching point we're trying to make. Echocardiography is not so difficult, and it's very rewarding, and it's a lot of fun. At least we had a lot of fun making this course. But we believe there's much more in echocardiography that we want to teach you. No matter if you're a critical care physician, a primary care physician, an internist, an anesthesiologist, or maybe a cardiologist in training. Therefore, we have a basics echo course for you, which we would like you to join. Because there you'll find chapters which will extend to what we've taught you here. We'll teach you more on aortic valve stenosis, more on left ventricular dysfunction and mitral regurgitation. In addition, we'll have chapters on pericardial effusion and pericardial disease, the aorta, we'll look at other valves, we'll look at right heart diseases, and much, much more. In any case, I think that this is something that we'd really like to offer you, and if you're interested, if we're able to make you hungry for more, just sign up on our site. Anna, thank you very much.